So maybe I guess this will be a very small, informal discussion. We advertised better to the NMOSD community, I think. I'm Alex Muccilli. I'm a neurologist at St. Michael's, and I see a lot of people with central nervous system autoimmune disease, including autoimmune encephalitis. And
yeah, I'm Julien Hebert. I'm a neurologist at the Toronto Western Hospital, and my specialty is epilepsy. And I see a lot of patients who have autoimmune causes of epilepsy, so autoimmune encephalitis and seizures and epilepsy.
Yeah. So we weren't really given a list of questions, but we'll maybe just have a brief discussion about things we think are important in recognizing the condition, and then maybe we'll leave some time for questions, and then we'll love to hear from you as well. So, Julien, what got you interested in autoimmune epilepsy?
Yeah, no, thanks for asking. So really, I didn't know which area of neurology I was interested in, and autoimmune encephalitis is a disease that affects multiple different areas of neurology. So it can cause seizures, obviously, but also movement disorders, cognitive issues, even peripheral nerve disease. So it was really a way for me to get exposure to different areas of neurology when I started it. And then I was impressed by how patients could do a lot better when they received the proper treatment early on, going from being severely cognitively impaired to in some cases doing very well and being able to resume their prior lives. So that was what made a strong impression on me.
When we were in the other room earlier, we were talking about how people can present with different symptoms, and I think one of the important things is that it's difficult to distinguish somebody who has a seizure related to epilepsy or some structural problem to people who have seizures related to autoimmune encephalitis. So, what are some signs that a seizure may not just be a run-of-the-mill seizure, but a seizure related to underlying brain inflammation?
Yeah, what a great question. So the burden of seizure, especially early on in their disease. So if they have a lot of seizures, multiple seizures per day within, I'd say, the first year of their epilepsy, that's quite atypical for somebody with a non-immune cause of epilepsy. And then there's a bit of an age factor as well, although patients with autoimmune causes of epilepsy can present at any age. Overall, they do tend to be older than patients with non-immune causes of epilepsy. And then epilepsy is just one of the manifestations of encephalitis. So many patients will present with a more acute encephalitic picture in which they also have cognitive and psychiatric symptoms that will require hospitalization. And then will receive treatment, and after discharge, unfortunately, some patients will continue to have seizures at home and develop a chronic predisposition to seizure, which is what we call epilepsy. And there are also testing that can be done to elucidate or to distinguish those from immune and non-immune causes of epilepsy.
I think one of the interesting things too is just how the seizures differ sometimes in their nature. Like as he was saying, they're much more common than they are in somebody who has epilepsy related to a brain tumor or an old stroke, or because they were born with epilepsy. These seizures start out of the blue and then they just occur constantly, and there's some kind of symptoms that point towards more of an autoimmune problem. Maybe you can tell them a little bit about that.
Yeah, no.
I find it kind of fascinating.
Yeah, no, thank you, yeah. So how the seizures present can also be a clue as to their immune nature. In particular, if we think of a disorder of a specific encephalitis called LGI1 encephalitis, so the numbers and letters, they describe a specific antibody that's involved in this encephalitis. They have a very stereotype type of seizure in which they have contraction of their arm and face on one side and then the other side, and that's called facial brachiodystonic seizures. And just by looking at the seizures, by looking at the patients, a diagnosis can be made really, in some cases, on the spot. It's very sort of specific for that disorder as opposed to other encephalitides and as opposed to other types of seizures from non-immune causes. And then in patients with NMDA, they will often have those, we think of them as more movement disorders, so they're called orofacial dyskinesia. So they look kind of more like chewing movement and rhythmic movement around the mouth, around their arms sometimes. And in the right clinical context, these can also be quite helpful in making the diagnosis of NMDA encephalitis. And then another common cause of another common immune cause of epilepsy is called GAD65. So again, all these refer to the specific antibody that's involved. And these seizures are often triggered by specific melodies or specific, even in some patients by specific songs that they might hear, and this will trigger their seizures. So that's also, it's not exclusively with GAD65 encephalitis, but it's very helpful if they have that feature. It's a lot more strongly associated with GAD65 encephalitis. We call it musicogenic epilepsy. So the seizures are triggered by music, and usually by specific kind of melodies, or at least genre of music. Yeah.
It's fascinating how one song may provoke it, but another may not. It's such a bizarre phenomenon. I had one patient who heard awful elevator music, and she was a high-level musician, so found that quite painful, but would also have some of those musicogenic seizures too. So I think it's a bizarre thing. One of the other ones is the goosebumps. I don't know if you've, I think mostly with LGI1, but patients either, they experience random bouts of goosebumps, and that also can be a sign of a seizure. Sometimes they're visible to people that are looking at them, and other times it's just an internal sensation. But they tend to occur hundreds of times a day, and it's quite a bizarre thing, I think, to explain to somebody else.
Yeah, the thought is that, so it can also happen in other types of epilepsy, but again, it's seen much more commonly in LGI1 than in those other types of epilepsies, and it's thought to be due to the part of the brain that's involved, the mesial temporal lobe, being involved with the autonomic system, which is a system that's in charge of our sort of the functions of our body that we don't have to think about, like our digestive tracts, our breathing, our heart beating, and likewise, we don't usually control whether we get goosebumps or not. And because that encephalitis attacks this part of the brain, it's thought that's why it can cause those goosebumps, which also would be a very helpful indicator that they might have LGI1 encephalitis, and something that we see in LGI1 a lot more than in other type of seizures. Yeah.
I guess it kind of highlights why there's often a delay in diagnosis, because you can imagine that if you go to the hospital saying that you feel goosebumps 100 times a day, and are having and behaving bizarrely, that people might chalk that up to a primary psychiatric disorder. And I think that's something we see a lot. People going to the hospital with symptoms and being dismissed by neurologists sometimes too, because until the symptoms become more prominent and we can see objective findings, sometimes we think it is related to mood, and that delay in diagnosis certainly has an impact on how people do, and it's important that we're aware of these conditions, that we spread awareness, that you share your stories, to make people more aware of these rare diseases.
I think there's been increased recognition of those disorders over the last, let's say, decade or so. But certainly lots of work that still needs to be done, and ongoing education that needs to be done on how these different disorders present. And certainly now that we have antibodies that can be tested, that's been very helpful in identifying those patients, but also I think there's been increased recognition for those more common subtypes, like the NMDA and the LGI1 being the two most common ones. For the rarer ones, still, I mean, for all of them, there's still, of course, room for improvement in recognizing those disorders. Yeah.
I will say on the flip side, I regularly receive referrals for people who have put their symptoms and who don't have autoimmune encephalitis into ChatGPT, and ChatGPT tells them that they have probable autoimmune encephalitis, and then they go see their family physician and they ask for a referral, right? So there is the also the risks of overdiagnosis. There was a nice study from the large American centers outlining the very high rate of misdiagnosis for people who didn't actually meet criteria for the disease, and and they showed that of those patients, 20% developed complications from the drugs that we prescribe, which are, really serious drugs, these medications, steroids, rituximab. So we also have to be cautious about overdiagnosis, underdiagnosis. Just the misdiagnosis in general is a dangerous thing, and
Yeah, I mean, I completely agree. Yeah, you don't want to overestimate the prevalence of the condition either, and if you can be seen by someone who has experience in that condition, I think that's the best thing that can happen to a patient. Either to be able to receive the correct diagnosis, and either to receive treatment early on, or to be redirected towards somewhere where the treatment is more appropriate to avoid the complications that can come with the immunotherapy, which is not a walk in the park, like you said. Yeah.
Do you think that there are tools or other resources besides neurologists that patients depend on as they're improving or adapting to their new baseline, if they don't completely go back to normal, which unfortunately many patients live with some degree of cognitive or psychiatric symptoms? I think you actually did a study on that.
Yeah, I mean,
Yes,
we did it together, I think, yeah. So, I mean, the originals, prior to autoimmune encephalitis becoming an entity, really, prior to us knowing that this disease existed, let's say in the mid-2000s, there were many patients who had encephalitis of unknown cause, who would be often quite sick in the intensive care unit, and they would be diagnosed with encephalitis of unknown cause. And then, fortunately, since antibodies were discovered, which allowed the identification of symptoms and sort of a constellation of symptoms and signs that can be identified as a disease, and then you find an antibody that goes with that. There's been many such patients who now we know have autoimmune encephalitis. And so the original studies focused on when these patients receive immunotherapy, essentially they're able to leave the hospital and they're able to survive. And which of course is a terrific outcome, is an outstanding improvement from before when patients would stay in the intensive care unit, and many, unfortunately, would not survive the hospitalization. But despite these tremendous improvement in the outcomes of those patients, we now know that even though they're able to leave the hospital and no longer need to be on ventilatory support, etc., there are still ongoing impairments in the form of cognitive impairment, mood changes, and epilepsy. Where was I going with that? I forgot.
Well, I think that...
oh, yes. So who else can...
Yes, who else can?
Yes. So our colleagues from psychiatry are very helpful in dealing with symptoms of mood changes and anxiety that are very prevalent after the acute phase of the disease, as well as our colleagues from rehabilitation medicine who can help cope with the cognitive impairment that's often seen in those conditions, and not just with more physical aspect of the condition. So not just going back to walking and being independent, but also being back to leading a meaningful, independent life. And then in terms of more broader psychosocial functioning, we're lucky we have a social worker in the epilepsy clinic who works with us and who has been helpful with some of our patients in either reintegrating the workplace that they were in before, or getting the support that they need to be able to cope with the condition in terms of sustaining themselves financially and navigating the resources that are available for them, paying for their drugs, getting coverage for services if they need them and if they're eligible for that coverage.
Yeah, similarly, I think we both treat the same disease but have different angles, and sometimes we have to rely on each other too. I send Julien people when, I can't get their seizures under control with a couple of different medications because he has a lot more comfort with using many anti-seizure medications and refractory epilepsy. And I unfortunately have a lot of experience trying to get drugs for people who need them in times where there's no approved therapy and have the resources of a very large clinic. And we do a lot of advocacy behind closed doors, writing letters to the government and to private insurers, and just trying to lobby to get our patients access. And that really does require a lot of time and support from a big clinic like ours. Unfortunately, we have a lot of relationships that are pre-existing because of a disease like multiple sclerosis. And although pharma seems big and bad, pharma has also paid for a lot of compassionate access to drugs for people who don't have multiple sclerosis. Sometimes we say people have multiple sclerosis even when they don't, so that we can get access to a drug. And it's actually a helpful resource and connection to have. So that does help us a lot from my perspective. Yeah. Do you guys have any questions? Yeah.
Maybe just relating to that last point, I'm wondering if you have any suggestions for us as advocates as to what we can do to accelerate that pace of change in encephalitis, especially with the access to treatment piece that you touched on. Because we look at NMO and see the approved therapies that are there now, and that's important for positive patients. The access is more readily there, and what can we do?
Yeah. Yeah. Okay. I think that's an excellent question. So the question was about what patients can do to help with access to different medications. And so aquaporin 4 positive patients now have access, or now there are several approved therapies, but in Ontario we still don't have access. And actually, it's a relatively complex thing even for that rare disease. We knew that for a long time rituximab worked for a disease like that, and we didn't have access in Ontario. But then rituximab actually became generic the same year that the drugs, that the large trials for NMO came out. And generic rituximab costs a very small fraction of the price of the newer therapies. And so now we have access to rituximab in Ontario for all aquaporin 4 patients. But now we're trying to advocate to get these other medications. So you can see it's a complex political thing. Of course, we want to, the government would like to not, to have the cheaper drug. And there is a small trial looking at rituximab for patients with aquaporin 4 positive disease, but certainly not as robust as the other ones. I only bring that up because that's a disease that's very rare, but has randomized controlled trial data. And that is actually the thing that helps the most. For autoimmune encephalitis, there's one randomized controlled trial that's been published to date looking at a placebo versus IVIG for LGI1. And they showed that that the IVIG was superior to placebo, which, I think arguably it would be unethical to give somebody a placebo with this devastating condition. There are many randomized controlled trials ongoing right now. The issue is that the enrollment is slow. So I was just speaking with one of the pharma reps about how we got St. Mike's to join a study for LGI1, which is a type of encephalitis that usually affects older men. And so after 6 months of work to get our site as one of the sites where they were doing the trial closed due to enrollment times taking too long, and so they just closed the study. And Julien and I offered our sites, which we see a lot of people with NMDA encephalitis. We tried to join the large American trial, and they said that they were having trouble with enrollment as well, but they were just trying to keep it to limited sites at limited centers. And so, I think when these trials close and we show that there's a clear benefit, access will improve. And I think at that point, we will really need to lobby the government together to list these drugs so that we have access. Right now, if we give patients medications in the hospital, our division absorbs the costs of those medications, and hospitals are in huge deficits, and so that kind of access doesn't come easily. It's a very complicated thing. I was explaining earlier that at St. Michael's, in the last 5 years, I've only successfully given rituximab to one individual. The good thing is, though, we have a very small catchment, and most of the patients that come for plasma exchange and then get repatriated back to another hospital that does pay for rituximab. So it's kind of constantly this dance or figuring out where we can move somebody so that they can get access. And I guess, I don't have a clear answer to your question. I realize I'm rambling, but you can see that it's complicated because I don't even know how we can advocate. Of course, I don't think the hospital is my friend, and we're constantly trying to advocate to improve access for patients. But it is challenging. There's some more success, though. I think, at the Western, I don't know why, but getting rituximab is marginally easier than at St. Mike's.
As an inpatient, yeah.
Yes, as an outpatient, you see that. That's why we have to depend on each other, because from my perspective, we can get it more easily as an outpatient because of our relationships, because of MS. So I think you can help by spreading awareness of the disease so that we can get to more people and offer them treatment. And then, we don't entirely understand how Ontario, or CADITH, which is the drug approvement organization in Canada, decides what drugs to approve and not. there's a panel of experts that advises the government, and then they actually do receive letters from patients. And the more letters that patients and physicians write to CADITH, that's what the organization is called, I think they listen to that, and sometimes we find out the drugs are approved, and we can change things. We've even seen it for MS, like half the drugs we use we didn't have approval for unless they failed like 3 other drugs before, but now we can get them first line. And these things are changing on a yearly basis. So the more we complain and advocate and annoy them, the more likely we are to get what we want.
Yeah, I completely agree. Yeah, I think strength helping the scientific and medical community strengthen the science behind the use of these drugs. If you can participate in trials or even just studies of outcomes that don't necessarily involve receiving a medication. I forgot the name of that medication, but there's a medication for Alzheimer's disease that was just recently approved, and I don't think the government was particularly keen on approving it, but if there's the science that's behind it to back it up, that makes a more compelling argument in the eyes of the government to provide for those medications. From clinical experience, we see that patients respond to those medications, but governments usually respond better to numbers, and in the scientific community as well, I think we also would prefer to have hard numbers, so to speak, to show the efficacy of those drugs. And then, some of us as neurologists are also involved in policy and politics. I'm not smart enough to be able to do that. I don't know like the system of making those policies, but I think reaching out to the CADITH and to those bodies, I think sometimes maybe it's hard for somebody in an office to kind of put a face or a story to those requests for medication approvals. It can be helpful.
The drug companies, of course, want their drug to be approved, so they will try and organize people to apply to the government, and that they're helpful in that way too, right? So, yeah.
Do you have any advice for getting involved in trials, like how to find them, how to apply, that kind of thing?
Yeah, the question was about how to get involved with trials. So, in Ontario, to my knowledge, most of the studies being done are retrospective in nature or prospective in that we're trying to understand more about this rare illness, and so agreeing to be included in a research project, your physician will usually ask you if you want to do that, and saying yes is a great way to start because this is a rare disease, so if we don't study rare diseases, we won't learn enough to know what we should do. To my knowledge, there's no randomized trial in Ontario that is drug-based for people who are newly diagnosed. Do you know?
No. I agree with you.
Maybe you can just tell them about your research.
Yeah, sure.
Julien is a clinical investigator, and so has looked at a number of different questions in autoimmune encephalitis. Yeah,
so I'd say the highest yield way of getting involved in research would be to ask your clinician if they are conducting any research or if they know of anyone that's conducting any research. In terms of participating in randomized controlled trials in Ontario, like Dr. Muccilli said, I'm not aware of any trial that's enrolling at one of the sites here. We're working towards having a trial for epilepsy with a center with some centers in the U.S., but there's nothing, concretely speaking, that's right now recruiting. a lot of most of the studies on autoimmune encephalitis are what we call retrospective. So they're sort of looking back at patients who had the condition and studying different aspects of the disease, maybe what the outcomes were, what did the investigations show, and even though the gold standard is prospective, randomized controlled trial, in medicine, actually, most of the evidence comes from those retrospective study. And a lot of those studies are done just using sort of the raw data that's available in the patient file, not the identifying data and so on. And so a lot of those studies, patients are often part of those studies without even being aware of it, just by virtue of having their medical files in the hospital system. So there's lots of studies on autoimmune encephalitis that are conducted that way, that don't require clinicians to obtain consent, because let's say you're looking at EEGs, which is a study that looks at brain waves in autoimmune encephalitis, looking at EEG data with antibody. This is all just sort of brain waves and antibody results. There's sort of no way that could be linked to a particular person. So, but nonetheless, that information is very important because it could, for instance, allow us to determine that certain patterns on that study are associated with certain autoantibodies. So, in fact, I would say if you've been seen, certainly at UHN, and were diagnosed with autoimmune encephalitis, you've probably been included in one of our retrospective studies without really realizing it. So that's not really answering your question because you don't have to do anything for that. That just sort of happens without you realizing it. But it's hopefully giving you some hope that even though you might not have been directly approached to participate in one of those studies, you might have actually been part of a study.
The other challenging thing is being part of a randomized study is maybe not always best. So, like for example, one of the aquaporin 4 studies had a placebo group, and in my mind, it's pretty unethical to have an aquaporin 4 patient who's not on treatment, just like having an encephalitis patient with a known antibody who's getting a placebo versus IVIG. I mean, so when even wanting to participate in trials, I would want the trial to allow the individual to be treated with the standard of care, and then comparing different add-on drugs. And so that's quite complicated because Canada, unlike the United States, is a very big place with fewer people. And so there's many different hospitals, and if you can't have a patient who's living in Thunder Bay be randomized to a drug trial in Toronto, so that would involve them coming here all the time. And that was one of the things we were concerned about when we were joining these trials. Like, we run MS drug trials at our center, and you have to come in to get an infusion or be assessed on a weekly basis. And when you have disability or you're not well, trekking into our hospital is a very big challenge. And we actually have recruitment issues even for multiple sclerosis. We have 10,000 people living with MS we follow, and we have trouble getting them into trials. And also as a physician, I'm not that comfortable putting a person into a trial if I think that there's a better option already available. So that is one of the challenging things right now. I think hopefully we'll have these trials completed in the next couple of years, I would think. I would think so. And that will help us with access and probably to come up with other questions that seem safe to ask and answer in a clinical trial format. Because once a drug like rituximab, for example, is approved, then likely the government will allow us to access it more easily. And then we can ask, well, is rituximab the right drug? Should we use this other drug? And then that's a trial we could do, even here. Yeah.
I have a question. So when I was a patient, an anti-NMDAR encephalitis patient, I was told that there was like a testing center in London, specifically
Yes.
Ontario, where it was assessed and diagnosed. I'm wondering what is involved in the diagnosis of something like that, like what kind of tests and things are done, just out of curiosity.
Yeah, we have a colleague who, so the question was about testing for the antibody panels. So there's different qualities of panels, and we want a test that picks up a lot of patients that have the disease, but that does not overdiagnose. So Adrian Budram, who's one of our colleagues and unfortunately couldn't be here today, spent a year at the Mayo Clinic, and with him he brought back the antibody panels and confirmatory testing that they had at the Mayo Clinic. So we, at our hospitals and at other hospitals, send panels, and there's kind of two series of tests. The first really identifies a lot of people, even people with low titers of the antibodies. And the second is a confirmatory test where they look on a mouse brain tissue to confirm that you actually have the appropriate profile, which allows us to confirm the test. And he's there, and he does 1 day of clinical work a week, and the rest of the time he's in the lab and doing research. And when he gets a positive test, he calls out to the physician that ordered that test, which is a very valuable service. So he'll call, if you're at, the Aurelia Hospital, he'll call the family doctor who ordered the test, because they don't have neurologists at the Aurelia Hospital, and he'll tell them, your patient has NMDA encephalitis. You can call Alex or Julien, and they will tell you what to do with your patient, or they will transfer your patient here, and they will guide you on how to the next steps. So that's what that lab does. It is, we're so blessed to have access to that testing. He's made it it's a comparable, he doesn't get money from the testing, but it's a comparable price to some of the other bigger commercial labs. There's a very big lab in Alberta called Mitogen, and that's where a lot of the other testing goes in Canada, but the confirmatory testing I don't think is as reliable as this lab. And so that's kind of how that works. And we if we get a negative test and we believe the patient has the condition, or a low positive test from another lab, then we'll try and repeat the test and send it to him. And then we'll communicate frequently. We're emailing and trying to understand things about testing in patients in the background to be able to get answers. So it is a little community of autoimmune neurologists and epileptologists and psychiatrists who work with these conditions, and we talk all the time, and we share our patients and our expertise.
Yeah, completely. Yeah, couldn't have said it better. And there's kind of a sense that sometimes from other clinicians, and there's sometimes a sense that it's sort of like a positive or negative. You put the blood test or the spinal fluid into a machine, and it spits out, okay, that's positive, that's negative, but there's actually a lot more nuances to it in terms of interpreting the staining patterns, interpreting the values, and that's the results of a long training, which Dr. Budram underwent, and we're very fortunate to benefit from his expertise in that way. I'd also add that testing in a way starts at the bedside when you're seeing a patient, examining a patient, and there are other tests in the more traditional sense that we take into consideration as well. But we never take the antibody test results sort of just in isolation. We link it to the presentation of the patient, and like Alex said, no test is perfect, so sometimes the test is negative, and then if we're really convinced based on the clinical picture that it should really be positive, then we can, again, repeat the testing, maybe with a different center, or be a bit more sort of, maybe skeptical is not the right word, but critical of the results that we get. And vice versa, by identifying patients who we think may have the disease in the first place, we avoid what we would call a false positive test. So any test, if you do it on enough healthy patients, eventually will churn out a positive result. So we have to be careful of that as well.
I think to that point, we often, we don't wait for the test result to start the treatment. Ideally, things occur in rapid sequence where we assess the patient, we think they have the disease, we send the panels, and then we start treating right away. We never really wait for these tests anymore, but often, you know, it's at least for NMDA and LGI1, which are the more common antibody-mediated encephalitides that we see, we often know very quickly at the bedside if somebody's going to have those treatments. I was just going to say that as a result of my interests, I do see actually quite a few people who are referred for false positive testing. So I see a lot of well people with normal exams who have fatigue or pain or, you know, some symptom that resulted in their doctor sending this test. You know, then, you know, it's a whole process in neurology of determining what results are relevant and are not relevant. So that's a challenging thing. There are also certain commercial labs available where kind of like the principle of Lyme testing. It depends where you send your test because there's a lot of false positives, and that can cause issues as well. Yeah.
Yeah. Completely.
Yeah, go ahead.
Oh, okay.
Yes.
I just need to make sure no one else has a question. I just had a question about if a patient has anti-NMDAR encephalitis, what could cause them to go into a coma? Like, what kind of, you know, medical explanation would there be for certain situations where that happens?
So the question is about what can cause people to be in a coma. And so in an NMDA encephalitis per individual. So there are different parts of the brain that allow us to be awake. There's the main highway of the brain called the brainstem. There are the thalami, which are kind of deep structures in the brain that control our consciousness. And then there's the top part of the brain. And if we have any major damage to these kind of three areas, then people will not be awake, regardless if that's caused by inflammation, by a stroke, by hitting your head, by an infection. You need those centers to be alert. And so part of what can happen in encephalitis is that it affects those centers of the brain and causes people to not be awake. Sometimes that impairment in their awareness is so severe that they need to be on a ventilator. Other times they don't need to be. They're just not awake, not interactive with their environment. But I think another really important thing that can occur is that people can have a lot of seizures, which causes them not to be awake. I don't know if you want to talk a little bit about status.
Sure. Yeah. So, many patients with encephalitis, including with NMDA encephalitis, can have several seizures. And if you have one seizure after the other, your brain can be stunned and not recover enough to be able to regain your awake sort of state. That's a common cause for requiring critical care medicine to be involved and admitted to the intensive care unit in autoimmune encephalitis. And sometimes patients will require to be sedated or anesthetized for a day, 2 days, sometimes longer, to allow the brain to cool off as the seizures become under better control. So that would be that's one common reason to be admitted to the intensive care unit with autoimmune encephalitis, including with NMDA. Otherwise the conditions,
I think
the
it's
situations
really,
that you mentioned.
it causes a kind of seizure that's really refractory to drugs, and so sometimes people are not awake for months. And that's partially because of the seizures, but also because of the drugs that we use to stop the seizures from happening. And having seizures occurring all the time is very dangerous for the brain. So, we want people to be sleeping instead of seizing while the kind of fire burns out at times. I think it's time for Sumaira to ask you all the questions.